Hello, my name is Bonnie-Ann Henderson, and thank you very much for inviting me to speak. My topic today is on negative dysphotopsias, the unsolved mystery. I have no financial interest on this topic. I do also want to credit Eve Geneva, who collaborated on this subject matter. I chose this topic because it is the bane of a cataract surgeon's existence, because oftentimes after uncomplicated, quote unquote, perfect surgery, patients can sometimes complain of dysphotopsias, both negative and positive. The positive dysphotopsias are the complaints of halos and streaks and arcs of light. So we're not going to focus on positive dysphotopsias for this talk, but instead we'll focus on negative dysphotopsias. Negative dysphotopsias are those dark shadows that people complain of in their peripheral temporal vision. It was first described by Jim Davidson in 2000, and the incidence is fairly high. It's up to 15% of patients immediately after surgery if you actually ask them. If you don't ask them, most people only complain of them approximately 1 to 2% of the time. The main issue with negative dysphotopsias is that the actual etiology of this dark shadow is a bit controversial, and the treatment is also controversial. In order to investigate the causes and treatments, we decided to do a review of the literature, and this is what we found. We found that most of the published reports were actually consultations, so it was really more opinions of what may be causing this rather than actual real prospective studies. We published this review of the literature in 2015. Here is a list of the etiologies that we found in the peer-reviewed published literature for the causes of negative dysphotopsias. We're going to focus on each one of those a little bit more in depth with each next slide. Besides having a functional anterior nasal retina, one of the most common causes of negative dysphotopsia is thought to be related to the design of the intraocular lens. It is hypothesized that lenses that have a sharp truncated edge increases a likelihood of a patient having negative dysphotopsia. And the reason is because as the light rays are hitting the edge, Jack Holliday hypothesized that the light rays actually cross at the actual sharp edge, and therefore there is a part of the retina that is not illuminated, and therefore that is a cause of the dark shadow. Compared to the rounded edge lens, there is no sharp cutoff, and therefore there is no dark shadow. That area is filled in with the light rays. Here is another view of a cross-section of the same idea by Jack Holliday from his publication of 2012. So this is a ray tracing of the shadow, and as you could see, the idea is that the light rays hit the sharp edge and therefore they cause a shadow of an area of the retina that is not illuminated. Another common cause of this shadow is thought to be related to the material that the lens is made of. We do see a higher incidence of the shadows in patients who have had an acrylic lens made of a high index of refraction compared to a patient who has a silicone lens, which is a lower index of refraction. And the reason is because the angle at which the shadow is made on the retina is much wider in an eye that has an acrylic edge, and therefore the shadow is much more noticeable because of the wideness of the shadow. So in the graph on the left, the retinal field angle that the shadow made of an acrylic lens is approximately 14 degrees compared to the angle in the silicone lens, and that's closer to about 2.5 degrees. And therefore, the shadow is much more noticeable in eyes with an acrylic lens. However, herein lies a controversy, because although there are reports that the incidence is higher in eyes with a sharp edge acrylic lens, negative dysphotopsia has also been reported to occur in all types of lenses, including silicone lenses and those with rounded edges. There was also another thought that maybe it has to do with a difference in the distance between the iris and the optic. However, in this study by Vamosi, they found that the patients who had severe shadow symptoms had approximately the same distance between the iris and the optic compared to the patients who were asymptomatic. And therefore, the distance between the iris and the optic did not seem to be a big factor. Therefore, this suggests that it is not just one cause of negative dysphotopsia. There may be several causes that combine to cause the shadowing. The size of the pupil seems to have an impact on the etiology of the shadow. Patients with a smaller pupil size are predisposed to having this negative dysphotopsia compared to a patient with a dilated pupil. And the reason is because people believe that the retina that is illuminated in a smaller pupil has a relative higher intensity of the shadow compared to a pupil that is dilated. So as you can see from the graph from the top to the bottom, the top image is a patient with a smaller pupil compared to a dilated pupil. And you can see that the height of the shadow is much bigger in the smaller pupil compared to the dilated pupil, and therefore would be more noticeable. Sam Maskett and Nicole Fram have done a lot of work in this field, and they strongly believe that this occurs because the lens is in the capsular bag and has an overlying anterior capsule rhexis edge. They believe that it has to do with the light rays as it hits the capsule on top of the optic and therefore causes the scatter to create the shadow. They also concluded that this shadowing can occur with any type of lens and not just acrylic lenses. If a patient has negative dysphotopsia in one eye, there's a higher likelihood that they will develop it in the second eye. And this may be because the patient's own anatomy is a contributing factor to causing the shadow. In these studies, they have shown that patients who have it in one eye are much more likely to have it in the second eye. So in some studies, the incidence of persistent negative dysphotopsia and bilateral negative dysphotopsia reaches up to 100%, and in some studies is around 50%. Bobby Osher published in 2008 that a patient's anatomy may contribute to negative dysphotopsia formation. He also agreed that there has to be a functional nasal retina, but also thought that maybe patients with a shallow orbit and a prominent globe may have an increased likelihood of developing negative dysphotopsia. Neural adaptation is hypothesized to play a role in negative dysphotopsia. One particular hypothesis is that there is this large-scale antagonistic receptor field center surround arrangement. In other words, the stimulation of an area of the retina results in surround inhibition, and therefore there's a larger contrast between the retina that is illuminated next to retina that's not illuminated, and therefore the shadow occurs. A second theory is that most shadows occur in the temporal periphery, and therefore it's hypothesized that it's the rods of the retina that are more involved. And since the rods are more involved, there's a failure to adapt to this overstimulation, and they continue to generate negative afterimages. While if the cone cells were involved, they would tire and lose sensitivity over time. Because the negative dysphotopsia shadow is transient, Bobby Osher believed that maybe it had a relationship with a clear corneal incision, since oftentimes the corneal incisions are made temporarily, and therefore maybe it was the temporary corneal edema that was causing the shadow. However, since then, other published reports have shown that negative dysphotopsia occurs even when the corneal incision is superior and covered by the lid, and therefore it cannot be just the temporary corneal edema from a temporal incision. So now that we've gone over the causes of negative dysphotopsias, what are the treatment options? So I've divided them into non-invasive and invasive approaches. For non-invasive approaches, the most common one is just to sit tight and wait. We oftentimes tell patients that this is temporary and that with time, the shadowing will become less noticeable and less bothersome. Some people have told them that if they wait for their posterior capsule to become opacified, that will occur. Some people have used dilating drops to dilate the pupil and therefore make the shadow less noticeable. And there are some recommendations that using some sunglasses might cut down on some of the shadowing. Some people have recommended wearing glasses with thick frames, and that blocks the light from the side entering into the pupil and therefore decreasing the amount of light scatter. And some people recommend just operating on the second eye with potentially a different type of lens and possibly placing the optic on top of the anterior capsule. And therefore, if they only have symptoms in one eye and not both, that their brain is more likely to adapt to the shadow and become less bothersome with time. For invasive approaches, because of the possible relationship between the anterior capsule and the optic, Holliday proposed possibly yagging the nasal portion of the overlying anterior capsule to remove it to see if this might help. Some studies have shown that this sometimes does help. However, it does not always help. So Folden had reported that in his study, approximately 50% of patients actually improved after a YAG laser. I found this percentage to be true. So when I do perform a YAG laser to decrease the shadowing, I counsel patients that this may only help some of the times and not all the time. The two most common invasive approaches is a reverse optic capture and piggybacking the lens. So with the reverse optic capture, you're prolapsing the optic anteriorly to be placed on top of the anterior capsule and thereby changing the pathway of light so that it does not hit the anterior capsule and then the optic. This has been shown to be successful in several studies, but again, not always successful. The second most common invasive approach is implanting a piggyback lens into the sulcus. The idea is similar in that this is creating another surface for internal reflection and thus creating more light scattering at the edge, which fills in that shadow on the retina. Other methods of invasive approaches is to change the position of the lens. In this scenario, some surgeons have recommended moving the optic anteriorly by fixating it on the iris. This has been shown to decrease the shadowing, however, it does not fully eliminate them. Some surgeons have attempted an IOL exchange to improve the symptoms. They oftentimes replace the lens with a rounded edge silicone lens with frosted optics. The idea is to decrease that sharp edge and fill in some of the shadowing by light scatter. However, this approach sometimes is effective, but oftentimes is not. And therefore, you have to counsel the patients that this may not completely eliminate the symptoms. Well, what about preventive approaches? So obviously prevention is better than treatment. So a surgeon may decide that instead of using acrylic high index of refraction lenses, they might choose silicone with a lower refractive index, maybe lenses with rounded frosted edges, or maybe try to alter the coverage of the optic with the anterior capsule by making a large capsule opening. However, negative dysphotopsia is multifactorial. And oftentimes you can't change certain things, such as you can't change the fact that someone has a functional anterior nasal retina, or that the lenses are really made to be inside the capsular bag with overlying anterior capsule, or the patient has a small pupil, or they may have a prominent globe, for example. So if your primary lens of choice is an acrylic lens with sharp truncated edges, then I propose a different type of prevention. Here is our new prevention approach idea. So if the one-piece acrylic lens is causing the shadowing to occur because the light isn't hitting the edge, approximately 1/3 of the circumference of the lens does not have an edge because of the optic-haptic junction. So the idea is if we can position the optic-haptic junction in the horizontal meridian where the light is hitting the edge, maybe we could decrease the amount of available edge and therefore decrease the likelihood that a shadow may occur. Here is a very simplistic diagram of how the intraocular lens should be placed in the eye. To study this hypothesis, we decided to conduct a prospective mass multi-center trial, and the purpose was to evaluate whether positioning the optic-haptic junction in the inferotemporal horizontal meridian will actually decrease the incidence of negative dysphotopsia. To evaluate this hypothesis, we decided to conduct a prospective masked multi-center trial where cataract surgery was performed with implantation of the Alcon Acrosoft one-piece acrylic lens. In the control position, the optic-haptic junction was placed vertically at 12 and 6 o'clock, and in the study groups, the position of the lens was the optic-haptic junction was placed inferotemporally in either the right or the left eye. The preliminary results showed that there was a very significant decrease in the incidence of negative dysphotopsia, especially on day 1 in the study eyes compared to the control eyes. The p-value was significant in the other centers as well. The patients were examined at 1 day, 1 week, and 1 month, and we compared the negative dysphotopsia incidence rates in the 2 groups using the combined data. The preliminary conclusions showed that positioning the optic-haptic junction horizontally resulted in a nearly 3-fold decrease in the incidence of the negative dysphotopsia. Because of the obvious difference in the results, we stopped the trial early but continued placing the lens only in the study position horizontally with the infratemporal optic-haptic junction position. Because of the strong preliminary results, we decided to stop the trial early and only continue placing the lens in the study position horizontally. We found that the incidence of negative dysphotopsia was significantly lower in the first week, 2.3%, compared with the 15.2% with the control vertical placement. Since our study, there have been new updates. Jack Holliday published 2 more important anatomical parameters. One is that eyes with a smaller axial separation between the iris and the lens, as well as eyes with a higher angle kappa, have an increased likelihood of negative dysphotopsia. He also agreed with our study that the horizontal position decreases the likelihood. However, I was focusing on the infratemporal, but it's actually the supraronasal haptic junction that is actually refracting the incidence light. Here is a diagram with the supraronasal optic-haptic junction circled. However, it is the same lens position as the infratemporal optic-haptic junction placed in the horizontal position. Jack Holliday felt that this horizontal positioning of the lens was one of the primary factors for negative dysphotopsia. There are several new IOL designs that are being created to decrease the likelihood of negative dysphotopsia. The image on the left is from Marie Tazignan. The one on the right is from Sam Maskett. Neither are available in the United States at this time. Several additional studies have investigated this horizontal positioning of the optic-haptic junction. This is by Jay Erie in 2019. And in his study, he also concluded that the horizontal haptic junction minimizes negative dysphotopsias. Here's a nice figure from his publications that shows the actual dark shadow formation. Manasseh and colleagues published in February of 2020 a prospective double-mass randomized control study looking at the orientation of the IOL. They also concluded that orienting the junctions horizontally halved the incidence of negative dysphotopsia in the 4th postoperative week. And therefore, their conclusion was that placing the optic-haptic junction horizontally is a safe and effective measure to reduce the risk of developing postoperative negative dysphotopsia. In conclusion, negative dysphotopsia is quite difficult to manage because it's multifactorial. There are certain risk factors that we can't change because they are related to the patient's anatomy. Focusing on prevention is better than trying to treat the symptoms once they have developed. And therefore, if you're using sharp-edged IOLs, especially with a high index of refraction, consider positioning the lens so that the optic-haptic junction is in the horizontal position. So thank you very much for inviting me to be a part of this conference, and I appreciate your attention. Thank you.